What did you do to ensure that cancer patients during the peak of COVID evidence are not left without planned and emergency care? And how were the patients' floors disturbed in your hospital, in your center?
Yeah. So I think I would answer this as such in a very clear way.
Mm-hmm.
The main thing when it comes to designing the workflow in this pandemic is you need to have a staged process of screening patients. And so the first thing that you need to do is to have very strong, before even infectious disease measures, but good screening measures to pull out potential suspect COVID-19 cases. So in China, in Singapore, we do it as such. We have a stepwise process. So we first screen them by their travel history, by the temperature, by the symptoms. For temperature, we use 37.3 and 37.5, different cutoffs. So long they have low grade temperature, we screen them. Now, if they have any one of the three, they get moved to the next level, which is either a CT scan of the thorax, because a lot of times we know that the test may be negative, but the scans may show changes.
Okay.
Yeah, so we do that. Now, if the testing is available, great, you can do the testing and the CT scan together. But if the testing is not available, then they should be rationed. That means only for patients who have a suspicious CT findings.
Okay.
So it's usually very characteristic. It will be ground glass changes, very interstitial-like atypical pneumonia changes. And if the patient has that, straight away, they go to the fever clinic and then they go to isolation. They don't even flow through because the key thing is not to contaminate other patients.
Okay. Yeah. I see.
So that's one. So then if they pass through all that, then when they come to the cancer hospital, then we do a few things. We stagger the patients to avoid overcrowding. So for example, at every point in time, depending on the space you have available, they should be at least 1 or 2 meters apart. Not too many patients present. So we treat about 2 patients every 30 minutes for radiation, for chemotherapy.
2 patients every 30 minutes.
All the healthcare workers are protected. So at least surgical masks. If they have direct patient-to-patient contact, if it's in the outbreak area, that means they have a cluster of cases, then is full personal protection, face mask, gown, gloves, everything. But if it's general area, that means non-outbreak area, then it's surgical mask and gloves and all that. The patients do not talk to each other, so they are isolated. We limit visitors. It's either no visitors or just one. And then they come in the same way, they leave the same way. That's how essentially we do the treatment. We also extend the design to healthcare workers, allocation of manpower for healthcare workers. So meaning all healthcare workers are split into 2 teams. They work on shifts. They don't have lunches. They don't talk to. They don't gather during team lunches. They all exercise aggressive hand washing. So the 2 important infectious disease measures that we implement is face mask and hand washing. So we have a lot of sanitizers, a lot of hand washing. They do that after every patient, and the patients do it themselves too, before they go and before when they leave. So those are patients on treatment. For patients on follow-up, we essentially cut down the numbers. We don't overcrowd the clinics. So again, they're staggered to every 30 minutes. If they don't have to come, they get moved to, on telehealth, or their appointments are postponed 3 to 6 months later.
Okay, if it's possible.
Yeah.
Your patients, probably there were some problems with the postponed treatment. So 3 months, it's rather big. So how you deal with it?
Yeah. So That's a very good question, and the truth is, it's an unavoidable consequence of this epidemic, of this pandemic.
Okay.
Give you an example. So when in Wuhan city before the lockdown, they were treating 200 patients a day. After the lockdown, the numbers dropped by 3 times because patients couldn't come back for treatment.
Yes.
Because also when you lengthen the process of treatment, because now the patients are treated, you can treat less patients a day. There's also a limitation on numbers. And 3, and most importantly, your healthcare workers are depleted. They either get infection or they are moved to cover the front line. So because of that, your numbers naturally drop down. Now, for some tumor types, you can get around it. So you either give chemotherapy first or you give hormonal therapy first. But for other patients, we try to shorten the treatment time, if they can. Unfortunately, there's no, so I've been asked this question, if it's COVID-19 positive or suspect COVID-19 positive, do you still treat a patient? The answer is no. Reason being because the risk to contaminate or infect other patients is too high. We know that cancer patients, when they get it, they are a lot worse.